Okay, good evening from the Immunisation Coalition. This is Susanne speaking. Before we let Angela Newbern present the webinar about influenza, I would like to make sure we do some of the housekeeping elements. So if you have questions, just use the chat function and I'll try and summarize some of those questions while Angela's presenting, and then she will answer them. And we try and keep on time, 60 minutes, and I'll hand over to you now, Angela.
Thank you so much, Susanna, and welcome everyone, and thanks for spending your start of your evening with us. So we're just going to do a 1-hour update on influenza. Some of you, I'm quite sure, are very, very familiar with this disease and know it very, very well. So let's just have a look at, what is influenza to start with, really. And I think we're all very much aware of that it's a virus infection. We do know that the range of symptoms can be as little as no symptoms at all. People can be quite asymptomatic and still be carrying influenza. And this is where we get quite concerned about influenza and how people can spread influenza without even knowing that they've got the virus and that they are spreading it quite well within the community. So many people that do get influenza, of course, symptoms can come on rather abruptly, usually 1 to 3 days after they've acquired the infection. Some people just feel a bit tired. Some people feel as though it's just a common cold. But obviously some people can develop really quite serious complications and certainly become very, very unwell. And at this time of year, we certainly start seeing are starting to see patients presenting to GPs and presenting to emergency departments because they are feeling exceptionally unwell with flu. And we'll talk a little bit about what our season is looking like further on in the webinar. We'll also be talking about these underlying medical conditions and comorbidities that some people have, and certainly the increase of myocardial infarct and stroke during flu season. The secondary bacterial pneumonia, that's really been quite well documented, and certainly there's been many investigations that have been done with the remains of people from the 2018 Spanish flu, where they have actually determined that many of those individuals died really because of a secondary bacterial pneumonia. So somebody's having trouble with audio, so hopefully they can get to hear okay. So let's just look a little bit further at flu. Viruses, as we know, do attack, particularly the flu virus attacks those epithelial cells that line the airways. And the roles of those two surface glycoproteins, hemagglutinin and the neuraminidase, you'll obviously see the H and the N, and that's pretty typical of how we talk about flu and which strain it is, whether it's a H1N1 or a H3N2, etc. And that's really talking about those surface glycoproteins, hemagglutinin and neuraminidase. They play really specific roles in the infection process when somebody contracts flu. The hemagglutinin molecules, that's what helps the flu virus attach to your healthy cells. And it initiates the process of breaking into the cell wall. The neuraminidase protein is responsible really for removing the sialic acid, which allows the virus, once it's replicated, to break out of that infected cell. and break through those protective mucus barriers of the respiratory tract. So both hemagglutinin and neuraminidase play exceptionally important roles when we're talking about how somebody becomes infected with flu, and certainly the amount of cell death that occurs when somebody has been infected with flu. So generally, our flu viruses are categorised antigenically as type A, B or C. We really only worry about influenza A and B viruses, and most definitely the A's, because the A virus is the one that can mutate so often, so easily, and really it's A and B flus that causes significant illness in individuals. Influenza C is a relatively mild illness. People really don't even know that they've probably got flu. So these influenza A's in particular do undergo those frequent changes to their surface antigens, and that's what helps flu virus be so efficient at evading our immune system, and is often, is what's going to be responsible for that, what we call antigenic drifting from season to season. So, which is why our flu vaccines need to change usually every year in order to keep up with those mutations or that antigenic drifting. When we talk about an antigenic shift, it means that it's a completely new virus, it's a completely different thing, and that's what we're going to be looking at if and when we get our next pandemic. So it's a bit of a guessing game for the vaccine manufacturers to how they are to produce their vaccines and what particular strain is going to be in the vaccines, and we'll talk a little bit more about that further on in the presentation. So this is an exceptionally easily spread disease, particularly from children who have very, very little cough etiquette, if any at all. They're quite happy to just cough and sneeze without covering their mouth and nose, and therefore they're very, very efficient spreaders of viruses such as influenza. So the virus does live on hard surfaces for around about 8 hours. So if somebody's touched a doorknob or a computer keyboard, for example, then they can certainly be passing on that infection to the next person that touches that doorknob or that keyboard. So definitely around flu season, or definitely if you've got a cough or cold, that type of thing, you're sneezing, definitely it's about hand washing and sneeze etiquette. So certainly have that alcohol-based gel on hand, most definitely. Influenza is usually a little more serious than just the common cold, because common colds don't tend to lead on to these sorts of very impressive and serious complications, which flu can certainly lead to. Obviously, we talked a little just earlier in regards to pneumonias being primary viral pneumonias or secondary bacterial pneumonias, and that is sort of what is perhaps more commonly seen. Certainly, the cardiovascular complications, and we'll be talking about these, in a little while further down the track in the presentation. Flu has a significant burden to the community. If you're working in a GP practice, I'm quite sure that you are well aware of how busy you become during flu season. But, looking at these particular statistics where there's going to really be quite high rates of disease in any given year, so quite a lot of patients that you will be seeing will be presenting with flu. Not everybody presents to a GP and gets diagnosed with flu. So it's a very, very underreported disease. And certainly when we're trying to look at deaths from influenza, rough estimate of potentially 1,500 to 3,000 deaths a year in Australia, but we're not 1,000% sure on that because it's the way the coding is done at the hospital level, and so not all influenza-associated deaths are actually reported as such. They're often reported as a stroke or as a myocardial infarct, etc., or as a pneumonia. But it's a hugely costly disease if you think of all of those 300,000 plus GP visits, all drawing a Medicare consult fee, hospitalisations, very expensive to be in a hospital bed, but it's just the lost productivity within the community as well, and the risks that are associated with flu on certain individuals in our community. So 2017, I think we will probably remember that one for a while. Exceptionally high number of confirmed influenza cases. Lots of hospitalisations and certainly deaths are associated with that as well. And if we look at what was circulating in 2017, it was predominantly a H3N2 circulating strain. Now that always will be a problem for us. If we've got a H3 year, we're probably not going to have a very nice year. H3 influenza strain just does not grow efficiently in egg culture. And all of the vaccines that we use here in Australia are grown on egg culture. So what will happen from time to time with H3 viruses is the hemagglutinin, that hemagglutinin glycoprotein, it just changes a little bit with the egg. So what H3 they actually put into the egg and what H3 variant they get back out of the egg to make the vaccine may not be the same. And therefore, you don't get a good match of the vaccine strain to what is circulating around the community. So these H3 viruses, have evolved over time, years and years and years. And so there have been changes to that receptor binding ability, and therefore that's affecting the quality, the quantity of the virus. So it's a really tricky strain of flu. In 2018, we had a really mild year. So instead of the 250,000 confirmed cases, we only had about 59, just under 59,000. But the circulating strain that year was a H1N1. So we've had a lot of exposures to H1N1 viruses over the years. If you think that, back to the Spanish flu days, the most, famous flu pandemic really was a H1N1 flu pandemic. So we've had lots of exposures to H1N1s over the years. But certainly in, 2018, we certainly had, like I said, lower number of cases. We had sort of lower number than, number of people that were reported as dying from that particular year as well. Deaths that were reported were generally, though, in the elderly. So it's really important that our older people do get these vaccines. Interestingly enough, even though we had less flu cases in 2018, ICU admissions were the same, really, and across all age groups, which was really quite interesting.
Angela, we've got a question here, which says, can we give the flu vaccine with pneumococcal 23? I understand Zostavax can be given with the flu vaccine.
Yes, so you can most certainly give an influenza vaccine and a pneumococcal vaccine on the same day. You can give influenza and zoster on the same day. You could actually give influenza, zoster and Pneumovax 23 all on the same day if that's what the patient is actually wanting. If they're more convenient for them just to have the one visit, you could give all three on the same day. So your 23-valent and your flu vaccines are inactivated. It's only your Zostavax that's the live virus vaccine.
Great, thank you.
Okay. So let's looking at who is at risk, and we've just mentioned that those that are over 65 certainly are at increased risk, and certainly the majority of deaths are going to be in people aged over 65 years. Our Aboriginal and Torres Strait Islander individuals are also at significant risk. We do know that our Aboriginal and Torres Strait Islander individuals have a higher risk of contracting disease. They have higher rates of hospitalisation at earlier ages than non-Aboriginal people, and they have longer hospital stays as well than the non-Aboriginal people. So it's really, really important that we protect all of our Aboriginal people against influenza. And thankfully this year, we are able to offer free influenza vaccine to all Aboriginal or Torres Strait Islander people from 6 months of age, which is absolutely fantastic news. Certainly people with chronic medical conditions and other risk factors are certainly at increased risk. Pregnant women, we learned a very, very horrible lesson back in 2009 with our little H1N1 pandemic that we had back then, where pregnant women were overrepresented in ICU departments, and a number of pregnant women died around the world, including in Australia. It really, really brought home to a lot of health professionals that pregnancy and influenza are definitely not a good mix, and we will talk about these risk categories in a few more slides. Once again, we've got more conditions that do increase the risk of severe influenza disease in individuals. In regard to people who are considered to be immune compromised, they have a reduced response to influenza vaccines. So if you do vaccinate people that are considered to be immune compromised, it's really important that as a health professional that we're really transparent about the fact that flu vaccine just will not work as well in them as it does in a healthy individual. Still most definitely worthwhile giving them a flu vaccine, but the likelihood is that they will potentially still contract flu disease, but it's the benefit of them not getting severely ill if they were to contract flu. People with HIV, if they have minimal symptoms and they've got a high CD4 count, then they develop reasonably good antibody titers for flu vaccine. But if somebody's got advanced HIV disease, perhaps they're not going to develop a good antibody response either. So with your chronic liver disease people, they can develop hepatic decompensation during these infections such as flu. Your individuals with Down syndrome, they have anatomical abnormalities that increase their risk of upper respiratory tract infections. So, and quite often they'll have other medical conditions as well that will increase their risk of severe influenza. And even though the obesity BMI of above 40 is listed there, realistically, anybody with a BMI of 30 or above is strongly recommended to receive an annual influenza vaccine. but certainly people who have that class 3 obesity level of above 40 as a BMI are particularly at high risk of influenza complications. Everybody realistically that is breathing is at risk of influenza. So when we're considering who should we vaccinate, it really is everybody over 6 months of age, even if they are a healthy individual. So really important that we have these conversations with people and make sure that they understand that they're at risk. We need to be mindful also that there is a difference between what is recommended and what is funded with vaccines. And unfortunately, not everybody is funded. However, they are recommended to have a flu vaccine. When we look at this particular list, we can look at people who are homeless, perhaps, their living conditions, and often their prevalence of underlying medical conditions mean that they really are predisposed to complications from flu and certainly able to transmit flu to other people in that particular environment. So whilst homeless people are just not on the list for free flu vaccine, they usually do have an underlying medical condition that would qualify them for a free flu vaccine. So let's take a closer look at these particular individuals that have got these particular comorbidities. People with cardiac disease, for example, you know, and although there really are a number of contributors, cholesterol-containing deposits or plaque on the arteries, in association with inflammation, are usually what is blamed for coronary artery disease. What we do know with influenza is that it induces this acute arterial wall inflammation, and through that process, it may well destabilise plaque, and therefore there is that risk of acute coronary syndromes. So influenza epidemics, we generally see significant increase in cardiovascular deaths. Acute myocardial infarcts do show a seasonal variation, and the highest incidence is in the winter months, which is exactly flu season. And there's been quite a lot of research that's been done looking into deaths of people in relationship to, you know, ischemic heart disease, and it is quite well documented that you know, people that have had an influenza-like illness in the weeks preceding their cardiac event, it's quite noticeable. So if you have individuals in your practice who you think, oh my goodness, they're a heart attack waiting to happen, or, you know, they do have high cholesterol, etc., please have that discussion with them about an influenza vaccine, because it just might be something that saves their life. So people with COPD, for example, we certainly know that, you know, this particular disease is really characterised by that irreversible progressive airflow limitation, and that airflow obstruction just really interferes with that that inflammatory process in the mucosa of the bronchi. So we know that flu viruses, they enter those epithelial cells, they replicate, and then they end up destroying those cells. So with that necrosis that sets in, it really contributes to that bronchial hyper-responsiveness. So they have this excessive, lot of mucus, excessive airway narrowing in these patients. So they're really at really quite severe risk of respiratory distress. With our patients with asthma, we know that repeated exacerbations of asthma, so repeated episodes where they become exceptionally short of breath, leads to chronic damage of the airway epithelium. This results really in lower airway function, poor airway clearance, so they can't cough up mucus as easily as somebody that doesn't have asthma. So they really have a really high risk of developing those lower respiratory tract infections. When we talk about asthma, and on the free funded schedule, it is for people with severe asthma, and that's really people who are on multiple medications for their asthma management and require frequent medical consultations as well. So asthmatics are really at increased risk of that secondary bacterial infection, Streptococcus pneumoniae, Streptococcus aureus, Haemophilus influenzae, all of those horrible bacterial infections that they are at risk of.
Another question,
Yeah.
the question is, are people who have had influenza or pneumonia in the past at increased risk or predisposed to influenza or pneumonia in the future?
That's a great possibility, because we do know that these particular diseases, whether it's an influenza or whether it is a pneumonia, can lead to long-term lung damage. So if you've got any damage to your respiratory tract or to your lung function, then that will certainly increase your risk of complications if you were to contract influenza again. We do know that once you've had an influenza, you do have lifetime immunity to that specific strain, to that specific variant, but it's really unlikely that you'll ever come across that specific strain and specific variant ever again in your lifetime anyway. So, like I said before, these flu viruses mutate and they evade your immune system because your immune system isn't recognising them as something that they've seen before. But yeah, if you've got respiratory damage, most definitely you would be at risk. So when we're looking at our diabetics, and you would have a lot of diabetics coming to your practice for sure. What we do know with diabetes is that any bacterial or viral infection, including influenza, does lead to significant morbidity and mortality in patients with diabetes. And that's really in part because of poor glycemic control. So they've usually got a little bit of renal disease, they may have some advanced age, they may also have some cardiovascular disease. But we do know the magnitude and the duration of hyperglycemic episodes is really strongly associated with that severity of the microvascular and the neurologic complications, which then add to the risk of infection. We also know that chronic hyperglycemia can cause that altered function in the capillary endothelium, rigidity of red blood corpuscles, changes how readily hemoglobin actually acquires and releases oxygen, from the surrounding tissues. So flu can really, really impact significantly on people with diabetes. Diabetics with poor glycemic control, it damages the elasticity of vessel walls. So when you're looking at somebody with influenza where there's a procoagulation effect, they really struggle to, pump this blood efficiently around their body. If we look at people who die from influenza who are diabetics, it's quite a sizable fraction of people that, where influenza and diabetes are just a really, really bad mix. So we know that, influenza is a cause of hospitalisations in working age diabetics, definitely when we're comparing them to working age non-diabetic people as well. We mentioned before about pregnancy and how pregnancy is a really bad mix with influenza. Flu vaccines can be given at any stage of the pregnancy, whether it's first, second or third trimester. The timing of vaccination, now that's the tricky part. The handbook will say it should be considered in relation to the influenza season and the availability of vaccine. Well, what is our influenza season? If we look at most years, we can say, yeah, we know that that's going to be around about August, September, October. But look at our notifications now. They are just unprecedentedly high for this time of year. So, when is the best time to vaccinate pregnant women? It's a really good question. But what we do know with influenza infection in pregnancy, it has been associated with approximately a 5-fold increase of perinatal mortality. So that's huge. Like I said before, pregnant women were overrepresented in intensive care units during the 2009 pandemic. The further along they were in their pregnancy, the more at risk that they were going to be in intensive care or they were going to die from influenza. We also know that there's this increased risk, not only with the perinatal mortality, but miscarriages and stillbirths and early neonatal disease and neonatal death. The problem with flu, particularly in the first trimester, is when people get the flu, quite often they will get a high fever. And it's this high fever that then raises the risk of a number of non-chromosomal congenital abnormalities. And these include things like neural tube defects, hydrocephaly, congenital heart defects, cleft lip, limb, reduction type defects. So really hard to know when do we vaccinate a pregnant woman, because we don't want her getting influenza in the early pregnancy because of these risks, and we certainly don't want her getting influenza later in her pregnancy because of all of those other risks. We know that those physiological changes that occur in pregnancy leave women at really great risk for complications. We know that in pregnant women that T-cell pathway, that cellular arm of our immune system, is temporarily altered during pregnancy. So we just don't have those T-cells that are out there being really active in, looking for flu virus and destroying it. So those changes are really, really important, and as a result, we need to be vaccinating pregnant women. Talk to them. Not only does it benefit for them, but also it's that antibody transfer across the placenta into that little unborn baby that's going to afford that little baby some protection against flu in those early months of its life. So travel, we all travel, and more of us are travelling. Look at the stats there, 1990, 4.5 million people travelled versus, in 2007, where there was, 900 million. So really, travel's a really big problem, and we're seeing this more and more. Is this what's causing us to have a little bit of an early flu season at the moment? who would know. We do know that it's important to vaccinate travellers against influenza. The last thing they were wanting to do was spend $20,000 on an overseas trip and spend most of that trip in bed with the flu or in a hospital overseas somewhere that's costing them a very large fortune. So if we look too at what's been circulating in the Northern Hemisphere, in America, for example, they reported their 2018-2019 flu season as the worst since the 2009 swine flu. So we generally kind of expect that what's happening in the Northern Hemisphere is what's going to be coming our way. So if we look at what's happened in the US, up until the 27th of April this year, so this is sort of tailoring off to the end of their flu season now. They've had around about 180,000 notifications, and the interesting thing for them is that their year started off being a H1N1 year, but throughout the course of the season, it's changed to being a H3N2 season. So is that indicative of what's coming our way? It's going to be really interesting to watch that. But just remember, if people are travelling, try and get their vaccines into them in a timely fashion, because it does take that 2 weeks really to develop that level of immunity where we've got reasonable protection against these sorts of diseases. So if we're looking at the handbook recommendations, it is really influenza vaccine recommended for everyone 6 months of age and over that are wishing to reduce the likelihood of becoming ill with influenza. And I think we just need to keep bearing this in mind. So every single person that we have contact with, that we communicate with, we really need to be having a discussion around flu. And I think we just probably need to reflect on how we have those discussions instead of just saying, oh, are you here for a flu vaccine, or did you want to have a flu vaccine this year, or are you going to have a flu vaccine this year, which are all yes, no types of answers. Maybe we should just sort of spend that extra minute or two, and I know in your busy work life that's really hard to find that extra minute or two, to really sort of say, look, glad that you're here. I'm just going to take a couple of minutes of your time to have a conversation around flu and flu vaccine this year. So it's more about instigating a conversation rather than just asking a yes-no question. So certainly there's groups that are strongly recommended, but it is actually recommended for every single person. Like we said before, there are some individuals who receive their vaccines for free, but there are people who are eligible for funded vaccine. And the list is readily available, and most of your state and territory flu schedules will list those individuals with these medical conditions that are eligible for funded flu. So when we talk about antibody levels, we also need to be talking about, how effective is our flu vaccine realistically? And we need to be really transparent about this because, unfortunately, the flu vaccines that we have access to aren't 100% effective in 100% of people that we give them to. In a really good year, in a nice healthy individual, we may get around about 60% efficacy. In somebody who's elderly and or somebody who's got a chronic medical condition, that might be reduced to 40 or 50% efficacy. In a year where we've got a really poor vaccine match to the circulating strains, that vaccine efficacy is going to be much, much lower than that. We've also got to remember that there are multiple strains of flu and multiple variants of those strains. And having a look at some of the work that the CDC in America do, where they've antigenically characterised 305 H1N1 pandemic 09 viruses during this 2018-29 season. Now, thankfully, 97% of those were antigenically similar to the Influenza A Michigan strain, which is a component of the flu vaccine that we are using here in the Southern Hemisphere this year. So whilst there's multiple variants, we've just got to hope that most of them are going to be quite similar to the strains that we've got in our vaccine. So we know that immunogenicity of flu vaccine is reduced in immune-compromised people. We mentioned that previously. However, there is still significant clinical protection that they can get from having that vaccine. We really need to be looking at improved technologies, and they are being explored so we can have more effective flu vaccines produced. The work that's being done around Australia around this includes adjuvanted vaccines, or around the world is in adjuvanted vaccines, and we're already using those in our over 65s. So our flu ad that's on our current NIP for the over 65s, and flu zone that is on available on the private market, or will be available on the private market, are adjuvanted vaccines. They're also looking at cell-based vaccines, and these are currently used in the United States. And those cell-based vaccines is where they've developed flu vaccine by growing it in canine kidney cells. So it's actually the kidney cells of a Cocker Spaniel dog, for example, that died many, many years ago. Recombinant flu vaccines, where they're using a host cell, such as an insect cell. So really exciting times ahead, but we've really got to be thinking outside the box and perhaps moving away from these egg-cultured vaccines. They're also looking at, the nanopatch technology. So could we be needle-free as well in, 4, 5, 6 years' time? They're looking at inhaled influenza vaccines, given the fact that this flu virus attacks the epithelial cells of the respiratory tract. So is it not a better idea to get the vaccine right onto those respiratory cells? So lots of exciting work being done, but just be aware that somebody can have a flu vaccine and they most definitely can still go on to get influenza, but those vaccine antibodies are going to be there and potentially stop them from getting really sick. When somebody says, I've had a flu vaccine and it didn't work, I still got the flu, we can look at that individual and say, okay, so you didn't end up in a hospital bed, you didn't end up in an intensive care bed, and you didn't end up in a coffin. So therefore, your flu vaccine actually did work. So we need to be really transparent about flu vaccines and people getting influenza. So 2019 state and territory vaccination programs for children 6 months to 5 years of age. Immunisation experts are calling for influenza vaccine for children to be included on the NIP. So that's a bit of a watch, wait and see to see where that happens. But certainly children are much more likely to contract flu in any given season. And we're talking around about 20 to 50% compared to 10 or 30% in adults. But during a pandemic season, 70% of children are likely to be catching a pandemic flu. So not only are flu rates highest in young children, but they contribute, like I said, to great transmission throughout the community because of their lack of cough etiquette, for example. And healthy children under 5 years of age are more likely than any other age group to be hospitalised for flu complications. So really important that once again we have conversations with every single parent around influenza vaccine for children. just be really aware that when we talk about adverse events from flu vaccine to people, we usually say, oh yeah, you might get a bit of a fever, you might feel as though you're coming down with the flu, you might get a few aches and pains, a few sore muscles, etc., etc. Just remember that those types of symptoms are exaggerated in young children. So please talk to parents about how to manage fever, how to watch for a fever, how to take a temperature. Putting a hand on a forehead is not taking a temperature. Ask them, do you have a thermometer at home? Do you have some paracetamol at home in order to manage this fever? Because flu vaccines in children are quite reactogenic. So just bear that one in mind. So like I said earlier, we do need around about 2 weeks to allow that antibody production to be to a level that it is protective. So make sure that people are immunised in time, but like I said, it's a really tricky question of when do we vaccinate people. We've really been thrown a curveball this year with this unprecedented number of confirmed flu cases for this time of the year, and I'll show you a graph just down the track. But yeah, we just don't really know what's going to be happening with this particular season. The big question that we get asked is, what about having 2 flu vaccines across the season? One earlier and then coming in for a second one to bump up our immunity. Problem with that is that there's really insufficient data to support that there's any benefit to that. And whilst there's no recommendation for it, there's also no contraindication to it. So it's a discussion to have with patients that are requesting 2 vaccines in the same flu season. Obviously, if it's children having flu vaccine for the very first time, then it's recommended, and they're under 9 years of age, that it's recommended they receive 2 doses 4 weeks apart. Same with people who the first year they're having a flu vaccine and they're currently immune compromised. So your oncology patients that are currently immune compromised, your HIV patients currently immune compromised, your solid organ transplant patients should have 2 flu vaccines 4 weeks apart if this is the first year that they're having flu vaccines as well, post-transplant, etc. So just bear that in mind, but otherwise have conversations with people that are inquiring about having the double dose, as we're calling it. So definitely, because those viruses are changing all the time, then so does the vaccine quite often. So there is some concern, of course, in regards to this waning immunity. So, what do we do about that? Most of the research is telling us that this is particularly among adults and especially those over 65. One Spanish study was examining waning immunity, and it was observed really that flu disease was lower in those individuals who received vaccine later in the season or later in the year when it was a H3N2 year, but didn't really find any differences in the risk of hospitalisation, admission for those people with influenza if they were vaccinated early or late if it was a H1N1 season. So that just poses that question about vaccine immunity waning. Does it then, depend on what is the circulating strain that particular season? So with our adverse events, we certainly know that there's common ones where people are going to get the sore arm. It might be a bit red. People can get significant redness around that injection site, but it's not a reportable adverse event unless the redness and swelling involves the joint above or the joint below the injection site. Like I said, there might be short-lived fever, but just watch that in children. Very rare would we see severe adverse events with a flu vaccine. However, they do happen. Certainly anaphylaxis can occur. Really important that we ask those people to stay around for 15 minutes after they've been vaccinated. Tell them what they're looking for. Can you please, make sure that you do stay around after I've vaccinated you? We wouldn't expect that there would be a problem. However, if you are short of breath at all, like you're having an asthma attack, if you've come out in a rash or you're feeling generally unwell, so just please let somebody know and they'll come and get me and we'll be able to manage that for you. So is it okay then if you stay around afterwards? That's great. And then you can go ahead and give your vaccine. No point giving the vaccine and then talking to them about waiting around, because you can't suck that vaccine back out again if they say they can't wait around. So always have that as part of your pre-vaccination mantra. In regard to egg anaphylaxis, people with egg allergy and egg anaphylaxis can receive flu vaccines. There is a very low risk of somebody with egg anaphylaxis of actually having an anaphylactic reaction after a flu vaccine. But because there is that small risk there, it is recommended that they're vaccinated in a facility where staff are able to recognise and manage an anaphylactic reaction, that they remain under observation for at least 30 minutes after immunisation. There was quite a large study, around about 830 egg allergic patients. 164 of those really described severe allergic reaction to egg, but really when they looked at that, only 2% of them had a really severe adverse event. And, they were generally, any adverse events that they had received, that they had experienced were generally actually mild. So if we look at flu vaccines, the composition for this year, there have been a couple of changes to this year's composition to the 2018 formulation, notably the H3N2 component. We have Switzerland this year, and that replaced Singapore last year. In the B strain vaccine, Colorado replaced the Brisbane strain. So we've got our quadrivalent vaccines there, and we've also got our trivalent vaccine, which is our Fluad. So that's our trivalent adjuvanted vaccine for our over 65s. Looking at the number of notifications to date, so this is back until for March. Certainly, things are looking a little worse for this year. So just bear that graph in mind, and then we look at what's happening now. You can see that blue spotted peak, which was the 2017 experience that we had, versus our 2018 experience, which is the orange dotted line, which is the lowest line. But if we come back here to our March-April timeframe, you can actually see where our notifications generally were sitting, and that solid green line is where we're sitting at the moment. So clearly an unprecedented number of cases for this time of year. What will that green line do? Good question. It's really a waiting game. It's really too early to assess what this season is going to look like. Flu seasons are really monitored throughout the season, but then generally assessed at the end of the season. But we know that GPs out there are very busy swabbing patients and diagnosing influenza. Hospital surveillance doesn't usually start this early either. So, you know, but we do know that flu patients are rocking up to emergency departments, and those presentations are certainly picking up around the country. What are we experiencing? H1N1 year, or is it a H3N2 year? The bad news is when we look at this particular graph here, we've got right at the tail end on the right-hand side, you'll see a couple of different shades of blue. That larger part of the bar, which is the darker blue, is a H3 bar. So certainly H3 is looking at this particular stage to be the more dominant flu strain. Now that may well change throughout the season, but I think we probably need to really be on our toes, thinking that this may well be a significant year for us. If we are looking at flu vaccine for this year, where the blue stars are, that means that it's on the private market. You will notice Fluorix Tetra is now registered for use and on the funded schedule for children from 6 months of age, but please note it is a full 0.5 ml adult dose. It's not a 0.25 ml like the Flu Quadri Junior. So when you're giving your vaccines, please do that 3 vaccine check before you administer any vaccines to make sure you've got the right vaccine for the right age group, because you will see on this table that we have got a number of vaccines available to us, and all of them potentially may have a different age group recommendation. We need to improve coverage. This data was from the 2009 adult vaccination survey, so fingers crossed we've had better uptake, but it's just so important that all vaccines that you administer are reported to the Australian Immunisation Register, because it is the best way that we are going to be able to gauge coverage. So have those conversations with everybody. So for those of you that are on the webinar that are practice nurses, you are pivotal, frontline healthcare professionals that have the opportunity to engage with patients and talk about flu. We know that recent research around general practice describes primary healthcare nurses as a multitude of hat wearers. So patient carer, an organiser, quality controller with your cold chain monitoring, etc., an improvement agent, a problem solver. You're an educator. You educate your patients, you educate each other, you educate the GPs, and you are the agent of connectivity with people. So you're in a prime position to be really influential. So just in conclusion, we know that many people are at risk of severe influenza disease, but bear in mind we have very healthy individuals who contract flu, who end up in intensive care, and who can die from flu. Unfortunately, here in South Australia, where I'm based, we have already had the death of a 15-year-old girl from influenza. So it can happen to anybody. We do know that people with chronic medical conditions or at-risk factors such as age or pregnancy, comorbidities, Aboriginality do increase the risk, but it can happen to anybody. So we really need to have those conversations with people, alleviate their fears around influenza vaccine, which is going to be easier said than done, and I fully appreciate that. Encourage those groups that are eligible for funded vaccine. So that's all your children under 5 years of age. It's all of your Aboriginal people, it's your pregnant women, it's your medically at-risk people. So offer it definitely to everybody that is over 6 months of age. Keep vaccinating, and I really appreciate the fact that you've joined this webinar, and hopefully you've found the information useful. So I'm just looking at the box here in regard to are there higher localised reactions in the over 65 flu ad? Yes, they certainly are. So we would expect to see an increased risk of particularly injection site reaction because of the adjuvant that's in the vaccine. So when there's an adjuvant in the vaccine, it attracts antigen presenting cells and to the injection site. So therefore there's going to be a lot more activity at the injection site while the immune system kicks into gear. So yes, we would definitely see that. What would be the recommended spacing for 2 doses in the same season? It's definitely a minimum of 4 weeks between doses if you are going to be giving 2. If you're not giving the flu vaccine and a pneumococcal, like a Pneumovax 23 or a Prevnar 13, if they're not given on the same day, there's really no particular interval, although particularly in children, because both Prevnar 13 and flu vaccines are quite reactogenic, they would recommend spacing them by 3 days. And Kate, you asked, why does there seem to be hesitation in recommending more than 1 flu vaccine in the same season? It really is, there's just not enough evidence to suggest that by giving a second dose of vaccine, it's going to produce a boosting effect. If it does boost immunity, by how much? Is it 1% or 2%, or is it 14%, or is it 26%? And there's just not enough evidence at this time for them to be making that recommendation. But, you know, research is continually done. You can give any other vaccine with a flu vaccine. So if someone is travelling and you're doing typhoid or Hep A's, you can definitely do a flu vaccine at the same time. There's no problem at all with co-administration of other vaccines along with flu. So flu vaccine can be given with Prevnar 13, it most definitely can be, but just talk to parents around fever. We are, here in South Australia, have a Bexsero program, and our babies at 12 months are receiving a Bexsero dose and therefore are receiving paracetamol 30 minutes prior to vaccination. So that's certainly helping, and they're getting their 2 doses of paracetamol post-vaccination 6 hours apart because of the Bexsero. So, but definitely talk to parents around management of fever. Does the air in the syringe need to be pushed out? Absolutely not. The air in the syringe is there for a reason. It helps you give your vaccine a little bit of a mix before you administer it and make sure that it's all mixed together again. When you put the needle to the person's arm, that air bubble will go to the plunger end. So therefore it's the air bubble that it's the last thing that goes through the needle, and it will clear the needle of any residual vaccine. Other literature will say that the air bubble is a good idea because it creates a little air pocket in the muscle fibres that allows the vaccine to sit there nicely for those antigen presenting cells to come to the injection site. So I
Excellent.
think that's all our questions answered.
Yes, thank you very much, everyone. Have a nice evening. And the recording and the slides will be available on our website in the next few days.
Thank you very much, Susanna.
Thank you, Angela.
Okay, good night, everyone.
Good night.